By age 2.5, Jack was showing signs of autism, difficulty in social interaction, language problems, repetitive behavior.
We were in functioning denial. We heard what they said. We didn't want to believe it. But, you know, Jack's 8 years old now. He's a wonderful kid. We still wonder every day what caused it.
Research reveals that it's likely there's no one cause of autism. Scientists say there's support for the notion that genetic mutations and pre- or postnatal environmental factors converge to interfere with early brain development.
Many experts believe that autism is a misconnection problem in the brain. The brain hasn't been wired correctly, and that leads one part of the brain to miscommunicate with another part of the brain, and that can result in abnormal behavior.
Is it a train?
In their quest to discover when and why this miswiring occurs, researchers rely on studies with humans. The most obvious signs and symptoms of autism emerge in children between the ages of 2 and 3. Scientists are working to identify the disorder earlier. For clues, they're studying the younger siblings of children with autism, whose odds of developing the disorder are an astounding 1 in 5. An important tool in this research, used in infants as young as 3 months, is the electroencephalogram, or EEG. A net of small sensors placed on the child's head permits the recording of the brain's electrical activity. It's like listening in on the conversation that billions of neurons are having with one another. The goal is to pick up on patterns of brain activity that are harbingers of autism. Researchers are discovering that there are features of the EEG that appear to predict when a child has an especially high risk of developing the disorder.
Here goes Jeff Gordon.
Earlier diagnosis will set the stage for earlier interventions and better outcomes for children. In fact, if science can intervene early enough, it may be possible to stop the disorder before it causes symptoms of autism.
If we could have gotten an earlier diagnosis, our life would be so different today. We would have been 6 months ahead of where we are, a year ahead of where we are, and Jack would have been that much better off.
Great introduction to what I think will be a fascinating discussion here on this disease that, as you know, the CDC now says probably affects 1 in 88 children, much higher prevalence among boys.
Our goal is to address autism as a public health challenge. As we saw it, autism is a neurodevelopmental disorder. We might be able to significantly attenuate the associated disabilities that really generate a societal cost of over $130 billion a year and $3.5 million a year for a child who is significantly disabled. I think we're truly at a crossroads in this field that we might be able to reduce the age of diagnosis and to improve access to care.
In all cases, we study an enriched population, that is, children at a very high risk, and the question for us is, how early in life can we predict which ones will wind up with autism? And then the inverse of that is, what's protecting those who don't develop autism, who still have an equivalent high risk?
On the general question, which I'm sure you hear all the time, why are we seeing what seems like a spike?
There are a variety of different factors that could be contributing to the increase in reported prevalence that we see. And it's important to note that these are reported prevalences and that the actual prevalence may be much higher. And there have been studies that we've funded in South Korea that would give some reason to believe that the prevalence rates might even be higher than that. You know, we're actually partnering with the CDC as we speak to do a similar study here in the United States. But from my point of view, we can debate the reasons why the prevalence has risen. One thing that doesn't change is that it's created a real increase in demand for services and a demand for a response.
One sentence probably will sum it up. We're finally getting things right. When I first started in this field, we talked about 4 individuals with autism per 10,000. The CDC now tells us it's 1 in 88. There are major factors, just as Robert's talking about. Awareness has been a key one, and Autism Speaks has been a major key in making autism something that everybody knows out there. It's also the case that we're finally ascertaining the patients. Just to give you one example, between the CDC surveillance report of 2002 and 2008, there was an increase among Hispanics of close to 101%. and among black children of about 96%. There is nothing epidemic that is happening in those communities, but we're finally reaching those communities, broadening of the understanding of autism, broadening of the definition, the awareness, the fact that, thank God, in the 70s, there was a change in the law in this country. So having this condition also means having an entitlement so the children can, their disabilities can be addressed. And then there are other issues of diagnostic substitution, for example. Given that there is great visibility to autism, many children that before carry a different diagnosis are now being diagnosed with autism.
If you plot the data over the last decade or two, it's still increasing. And there's no reason to think, even with the DSM-5 now becoming the new standard for diagnosis, to think that it's suddenly going to flatten out. Currently, the treatment options for children with a diagnosis are probably still limited, and limited both in the range of treatment options as well as the availability of the treatments. A related question, though, is if we're able to diagnose kids much sooner than we can now, then the demand will increase exponentially, and the treatment options will have to change because now you're treating 6-month-olds instead of 2-year-olds. And these are complex issues that I think need to be given some thought.
Early diagnosis and hence early even behavioral treatment leads to better outcomes. So therefore, there is no substitute for early diagnosis. Autism is diagnosed, if I may say so, in a very soft way. There is no blood test for autism. There is no, eventually, as we understand genetics better, there may be genetic tests, but even then, genes and environments contribute to make autism. Autism is highly genetic, autism is familial, but then there are sporadic mutations that can also lead to autism. So all of this makes it a very complex issue. Nonetheless, I think that the better the criteria by which we diagnose autism, the more stable would be the diagnosis across the population. And the earlier we can diagnose based on markers, such as what you saw in the video that both Ami and Chuck are developing, as well as all other kinds of biomarkers, that will lead to early diagnosis, early treatment, such as they develop, and hence better outcomes.
There's a real need, hunger for more objective, precise ways of calling a case a case. This is not unique to autism, and in this way, I think autism stands to benefit from a larger effort, a larger movement to diagnose mental health issues in an objective manner. And in fact, we might find that the boundaries between autism and other psychiatric indications as we define them today to be blurred over time.
What we are saying is this enormous plasticity afforded by basically what is the year of greatest brain change in our postnatal life. And so we have been focusing a lot on identifying markers that they may be behavioral. They are produced sometimes in experiments, as you saw in the video. But the question is, we have to move that into where the children are. And I mean children universally. The children are seen in a medical home by primary care centers. We need to transform those kinds of insights into something that is going to allow us to implement universal screening for these children. Early intervention works, but it works because it's not only that we're treating autism, we are preventing the things that autism is associated with, which is actually accounts for the greatest portion of those $136 billion a year. Our children develop intellectual disabilities, language disabilities, severe behavior challenges. Centers such as ours need to deploy treatments that cost in excess of $100,000 a year in order to treat a child that cannot be in the school. If we manage to get children to speak by the time they are 3 years of age, their program is going to cost $6,000 a year, and they're going to be in regular schools, and they're going to be benefits from the presence of their peers. So the economics of autism is stupid. To be very blunt, we are really at a crossroads. Only 20% of children who carry an exceptionality of autism in the school system are identified below the age of 3 years. So we have a lot of work to do, and the partnerships need to go from the major scientific labs like at Harvard and MIT and other places right into the community where the children are seen, supporting that triangle of primary care centers, early intervention programs that are really starved for any form of resources, and the families, because some of those treatments are going to happen in the homes because we need to advance community viability in our novel solutions.
Even with the best treatments, A, not all children benefit, and B, of those that do, there's still no strong evidence that one loses their autism, that we improve their functioning, but we don't cure them.
We basically define autism as a set of symptoms. We are working on the hypothesis that autism is the result of deviation from the normative process of socialization. The reason why we're adopting that is because otherwise, as we heard today, we would treat stroke after the person has stroke. Why should we do that? Why should we begin to treat autism only by the time in which autism is already established? And children of autism become adults with autism. So the work that you've seen here today is work on autism creating itself, in a way preventing autism from creating itself and instantiating this enormous complexity of genetic liabilities that I can speak to.
When a disorder strikes a child hasn't had too many life experiences. So we take it as a starting point that something has gone awry in the way that the child's brain has been built. And that means beginning with the genes. We can do genotyping. The technologies for genotyping are proceeding rapidly, and they have begun to yield fruit in terms of what are the genes that underlie autism. There are rare forms of autism in which even a single gene, even a point mutation out of 3 billion base pairs that make up your genome and mine, one base pair, if it's flipped, can underlie autism, particularly if it is in a critical protein coding region of some gene. At the other extreme, multiple such flips may contribute to autism. The rare conditions are now beginning to be well understood, and they do provide us with model systems. We can make mice in which we can flip these same genes, or we can delete these same genes, and we can ask, what can the mouse not do? Now, mice don't get autism, but mice do have changes in their brain as a result of this gene that is also common to a human being who has autism. And we can ask then, what is wrong in the brain? So these are some of the ways in which we can take cells from a human being's skin and transform it into neurons. These neurons don't share the person's life experiences, but they share the genetics. So we can ask, what can these neurons not do in a dish that normal neurons, or neurons in which this mutation has been read through, do? So these are some of the ways in which we can begin to probe, what do the genes do?
What's promising in the treatment realm?
The platform for brain development is reciprocal social interaction. The reason probably why autism is so common is because you're disrupting something that every child needs to conquer. The children are learned, they are born to interact with others, and it's out of this mutually reinforcing choreography between baby and caregiver that a lot is of importance for development emerge. And so our ability to intuit other people's feelings, to communicate with others, to learn about the world within the context of culture. This is the platform. If that platform is disrupted, so we have to address that problem. And some of the very promising early intervention models that we currently have address that. Issues with social communication, foundational issues that basically impact the children from very early on in their lives, and basically make their experiences diverge from those of their typical peers.
So where are you intervening then? At 12 months, you think, is that an accepted, appropriate?
That's very rare.
Oh.
In the community, that's not the case. The vast majority of children are not being identified early, and we don't have, as a community, the resources to provide that kind of scaffolding for this interaction. But that's exactly where the focus of the work is not only create something that is going to potentiate the contact between the child and the caregiver, but also create a model that is going to be viable, something that can achieve the level of intensity in the home so that every waking moment of the child is a moment of therapy. That's one of the big issues. Our children are moment by moment in their infancy and toddlerhood years, they are diverging from what is happening with the experience of their typical peers. And unusual behaviors becomes unusual brain. And soon enough, you have a crystallized brain that is taking the children on a different course.
Are you targeting 12-month-olds who are showing signs and features of autism, or simply those at risk for autism? And then maybe you could tell us a little bit about what the intervention looks like.
By the time the babies are 6 to 9 months, they are accomplished social interactionists. And much of the social reciprocity that you are seeing in those babies, unfortunately, are things that we are not seeing in our children with autism by the time that they're 4 and 5 years of age. Reciprocity means that we can have a conversation without words. Babies are capable of having these prosodic conversations. Now, these are critical milestones for communication, things that our children don't go through. Those become the envelopes where words are later placed. And our children, when they do learn language, they may have a very monotonic sort of robotic voice. They speak like that because they have the words, but those words have not been learned within the context of social action and interaction. So they don't have what, those kinds of hallmarks of infancy, which is this basic cries and sounds that bring me together with you, and we co-create a world. The model of treatment is a model that was created by Amy Weatherby, a collaborator with us from Florida State University, together with Catherine Lord from Cornell here in New York. And the notion is that we are potentiating social interaction. So there are ways of being with a baby that is going to, in a way, scaffold that environment so that babies begin to understand the reward value of being with another, getting things in the world, in a way trying to do what they should be doing, where they to be following a typical development, but they are not. We see this attenuated sense of the other. So what we're doing is basically pushing social interaction forward in a way that it's not only done in the laboratory, but mothers are treated to do that at every moment of their child's waking life in real life situations. When the child is being bathed, when the child goes to the supermarket with mom, or mom is cooking, because every moment of the child's life is a moment of socialization. And we need to create that situation in people's homes.
A lot of this happens normally as a typically developing child goes forward. It somehow falls behind for a child who's on the autism spectrum or is not developing normally, and the more we can provide it, the better. It'll be a long time before we will intervene and repair the gene. But by understanding what the genes do, we can come up with therapeutics that could intervene downstream of the gene and perhaps repair some of the dysfunction in synapses or in brain circuits that have gone awry.
Dr. Nelson, when you think about what are you most excited about if you're looking at treatment possibilities that are on the horizon?
Well, one is the ability to implement them in a naturalistic context at a very early age.
Naturalistic meaning?
Meaning that social interaction, things that come naturally. So to encourage parents to engage in a lot of discourse and face-to-face communication, a lot of eye contact, those things come naturally. Probably those are going to be part of the bread and butter of an effective intervention that's applied early. I think a second thing is the ability to look for markers that indicate that you've changed the circuitry that underlies those things. So when you see a 12-month-old not responding to his name when you call his name, or being fascinated by the numbers on that screen and having no interest in people, and then you do an intervention that suddenly gets them tuned into social interactions as though a light switch has been turned, we need a marker of that so we know precisely what's happened. Because the more we know about the underlying circuitry, the more we can develop very targeted interventions. And let me use as a model here. In this country, we've been doing early intervention for children growing up without resources. Head Start would be one example. And invariably, these are applied for a limited number of hours at a limited age span, and many of them have proved to be helpful, but not curative. And I think there are lessons we can learn from where they failed as we apply those things to things like autism. This discussion of social interaction can be misconstrued by many parents to think that they're to blame for their child developing autism, or conversely, that they feel guilty that they're not doing enough in the social sphere to prevent autism. And parents have enough to feel guilty about it, we're hardwired that way. And so we need to be mindful that the treatment isn't presumed to also be the underlying cause of, because many parents will think, I'm not interacting with my child enough, and that's what causes autism. Second, to go back to an important point Morganka was making, is that the population of kids who wind up looking like they have autism are probably genetically vulnerable kids, and something has happened to make them deviate from a typical developmental trajectory. And it may be that these interventions will work for a subset of those kids, but it may not work for all of them. And to use a coarse expression, we may need to supercharge those circuits somehow, and that's where the pharmacological interventions may come in. The downside is we have to know who would benefit from them. We don't want to be wrong in giving the drug to someone who doesn't need it, and we need to make sure that there's no harm in playing more with your baby, but the risk of a drug could be considerable. So we need to be very mindful as we approach it from that end. But my bet is, like the treatment for, say, depression or anxiety, it's going to be a combination of getting these circuits souped up somehow in the vulnerable kids and then blasting them with these behaviors that Ami's been talking about.
What do you want from parents or adult patients to assist in your work? Is there a role for them to come back and?
Well, my impulsive answer is going back to the cancer model. We need more buy-in from families to be involved in research and of all sorts, not just the causes and what's going on, but also on the treatment side. So we need more clinical trials, which is the standard in cancer, but it's not in autism.
But autism is not one thing. My friends who are statistical geneticists tell me there will be at least 400 to 500 genes that might underlie autism. Why so many genes? It takes 2,000 proteins to make a synapse. And there are 1,000 trillion synapses in our brain. But autism is fundamentally, we believe, at least some of us believe, is a disorder of synapses. So there are a lot of ways that you can mess up a synapse. And if you mess up synapses in certain critical regions of the brain that underlie the symptomology of autism, the social brain, for instance, then you get autism. So there are many ways by which you can mess up the social brain or the parts of the brain that are involved with making social interaction, which is the key cardinal symptom of autism. Hence, there will be many ways of then perhaps repairing it. But to get to them, you need the right patient population, the right model, and the right therapeutic.